Hello friends, today here we are with neonatal seizures, a very long awaiting period for you on this topic. So we will talk on neonatal seizure. I am Dr. Naveen here. Objective of this lesson is to know the definition of seizures, classification of seizure, neonatal seizure, epidemiology of neonatal seizure, classification of neonatal seizure, common causes of neonatal seizure, approach to a newborn with neonatal seizure, management of neonatal seizures. Definition of seizure. Seizure is defined clinically as paroxysmal alteration in neurological function such as motor, behavioral and or autonomic function. This definition includes epileptic seizures. It is associated with corresponding EEG seizure activities such as clonic seizures. Non-epileptic seizures, clinical seizures without corresponding EEG correlation such as subtle or generalized tonic seizure, and EEG seizure, abnormal EEG activity with no clinical correlation. Now neonatal seizures. Neurological dysfunction in newborn and infants can present frequently with seizures. Infant and newborn with neonatal seizure are at high risk of death during neonatal period and neurological impairment and later on epilepsy disorder in the life. The mortality due to neonatal seizure has decreased over years, but the prevalence of neurodevelopmental sequelae has remained unchanged. Now epidemiology. The National Neonatology Perinatal Database NNPD 2002 to 2003 speaks an incidence of 10.3 per 1000 live births, and incidence increases with decreasing gestation and birth weight. Preterm neonates 20.8 had twice the incidence when compared to term 8.4 per 1000 live births. Very low birth weight neonates had more than four-fold higher incidence, 36.1 per 1000 live births. Classification of neonatal seizures. Four major types of neonatal seizures. Subtle seizures, they are the commonest type, almost 50% of all seizures. They are called subtle because the clinical manifestations are mild and often missed. There are five categories in this. Ocular. First is ocular, tonic horizontal deviation of eye. The neonate presents with tonic horizontal deviation of eye towards one side, or sustained eye opening with ocular fixation or cycled fluttering. And second is oral, facial, lingual movements such as chewing, tongue thrusting, lip smacking. Third one is limb movements, cycling, pedaling, boxing jabs, etc. Fourth one is autonomic phenomena such as tachycardia or bradycardia, and fifth one is apnea, cessation of respiration, rare manifestation, but apnea due to seizure activity has an accelerated or a normal heart rate when evaluated 20 seconds after the onset, and bradycardia may occur later due to prolonged hypoxemia. Subtle seizure with sustained eye opening, you can see here. Horizontal deviation towards one side of the eye, some cyclic movement in between. Second one is boxing jabs, cycling and pedaling, limb movement. You saw here the newborn having boxer like posture in the both upper limbs, and cycling and pedaling of the both lower limbs. Cycling, pedaling movements such as running a cycle. while putting the foot on the pedals. Now orofacial movements, you can see here, twitching of the corner of the mouth of one side. Now next one is clonic seizures. First was subtle seizure, second one is clonic seizure. They involve rhythmic movements of muscle groups. They have both fast and slow components, occur with a frequency of 1 to 3 jerks per second or 1 to 3 hertz, and associated with EEG changes. And you can see in this picture how the clonic seizure look like. This is focal neonatal clonic seizure. This is clonic neonatal seizure. You can see one side of the body. Third one is tonic seizures. Tonic seizures have sustained flexion or extension of the axial or appendicular muscle groups. This seizure may be focal or generalized and often resemble decerebrate or decorticate posturing. There is no EEG changes in generalized tonic seizures. You can see here the flexion, sustained flexion of the upper limb and the extension of the lower limb here, and there is increase in tone of the limbs. Fourth one is myoclonic seizures. Single or multiple light fast jerks of upper or lower limbs are usually distinguished from clonic seizures because of three parameters: rapid frequency of myoclonic jerks, absence of slow return, and predilection for flexor muscle groups. You can see here in this picture myoclonic seizure, very light fast jerk. Common changes on EEG includes burst suppression pattern, focal sharp waves, and hips arrhythmia. Myoclonic seizures have worst prognosis in all of the above, and clonic seizures have the best prognosis. Common causes of neonatal seizures. The most common cause of seizures are hypoxic ischemic encephalopathy, metabolic disturbances such as hypoglycemia and hypocalcemia, and meningitis. First one, hypoxic ischemic encephalopathy. HI secondary to perinatal asphyxia is the commonest cause of neonatal seizure. Most seizures due to HI starts within first 12 hours of life, while the rest manifest by 24 to 48 hours of age. Other complications like hypoglycemia, hypocalcemia, intracranial hemorrhage may coexist in neonates and should be excluded. Subtle seizures are the most common types of seizures in neonates with HIE. Second one is metabolic cause. Hypoglycemia, hypocalcemia, and hypomagnesemia, pyridoxine deficiency, and inborn error of metabolism consist of causes of metabolic origin. Third one is infection. Meningitis should be excluded in all neonates with seizures. A meningoencephalitis secondary to intrauterine infections such as TORS group syphilis may present as seizures. Fourth one is intracranial hemorrhage. Most seizures due to intracranial hemorrhage occur between 2 to 7 days, and seizures occurring in term well neonate on day 2 to 3 of life is often due to subarachnoid hemorrhage. Preterms having intraventricular hemorrhage terms usually have subarachnoid, intraparenchymal, or subdural hemorrhage, and very rarely extradural hemorrhage, which is not usually seen. Fifth one is developmental defects. Cerebral dysgenesis and neuronal migration disorders are rare causes of neonatal seizures. Sixth one is miscellaneous polycythemia, maternal narcotic withdrawal, drug toxicity such as theophylline, doxapram, and local anesthetic injection into the scalp, tuberous sclerosis, incontinentia pigmentae. Accidental injection of local anesthetics into the scalp may be suspected in the presence of fixed and dilated pupil and absence of Dole's eye reflex. Multifocal clonic seizures on fifth day of life may be related to low zinc level in CSF, benign idiopathic neonatal convulsions. Seizures due to subarachnoid hemorrhage and late onset hypocalcemia carry good prognosis, while seizures related to hypoglycemia, cerebral malformation, and meningitis have a high risk of adverse outcome. Now, a new thing, jitteriness, differentiation of jitteriness from seizures. Jitteriness is the tremulous movement of the limbs. In jitteriness, there is no abnormal eye movement, while in seizure, abnormal eye movement is present. Jitteriness is sensitive to stimulus such as loud music, loud voice, and light, etc. can precipitate jitteriness, but seizures are not stimulus sensitive. Jitteriness stops with passive flexion, while seizures do not stop with passive flexion. And predominant movement in jitteriness is tremors, while in seizures is clonic jerks, and autonomic changes are absent in jitteriness while present in seizures, such as tachycardia or bradycardia. Approach to an infant with neonatal seizure. Neonate with seizure, you have to identify and characterize the seizures. Before doing that, secure airway, optimize breathing, circulation and temperature, start oxygen if needed, secure IV access, take blood samples for baseline investigations. If hypoglycemic, blood sugar less than 40 mg per dl, administer 2 ml per kg of 10% dextrose IV, and then follow continuous infusion of 6 to 8 mg per kg per minute of dextrose. And if hypoglycemia has been excluded, the neonate should receive 2 ml per kg of 10% calcium gluconate IV over 10 minutes under cardiac monitoring. And if serum calcium are suggestive of hypocalcemia, the newborns should receive calcium gluconate at 8 ml per kg per day for 3 days under cardiac monitoring. And if hypoglycemia and hypocalcemia are ruled out, and even if seizure persists, we have to administer phenobarbital 20 mg per kg IV stat over 20 minutes. And even if seizure persists, repeat phenobarbital in 10 mg per kg per dose until total 40 mg per kg per dose is reached. And seizure ever persists, administer phenytoin 20 mg per kg IV slowly over 20 minutes under cardiac monitoring. Even if seizure persists, repeat phenytoin 10 mg per kg per dose. Seizure continue, consider lorazepam or midazolam IV bolus or infusion if needed. If seizure continue, give bolus or midazolam infusion if needed or to be continued. If seizure controlled, we have to wean anti-epileptic drugs slowly to maintenance phenobarbital. Now here you have seen there in the management, there is not somewhere levetiracetam has been mentioned, and so levetiracetam or lidocaine may be considered as second line agent in place of phenytoin. If there is no phenytoin is not available, you can give levetiracetam or lidocaine. Now I have said lorazepam or midazolam infusion or bolus. So what are the dosage? Lorazepam is given 0.05 mg per kg IV bolus over 2 to 5 minutes and may be repeated, and midazolam 0.15 mg per kg IV bolus followed by infusion of 0.1 to 0.4 mg per kg per hour. Investigations required in neonates with seizures. Essential baseline investigations include blood sugar, serum sodium and calcium, CSF examination, cranial ultrasound, electroencephalography EEG, and additional investigation include hematocrit if plethoric and at risk for polycythemia, serum bilirubin if icteric, serum magnesium, ABG and anion gap if lethargic, vomiting or family history is present. Imaging such as CT and or MRI if no etiology found after essential investigation. Torch screen for congenital infection. Workup for inborn error of metabolism. Anti-epileptic drugs for seizures refractory to above treatment. First one is lidocaine. Lidocaine we have seen previously, it is used instead of phenytoin. We can in place of phenytoin. So usually administered as bolus dose of 4 mg per kg IV, followed by infusion rate of 2 mg per kg per hour. It is tapered over several days. Adverse effects include arrhythmia, hypotension and seizures. It should not be administered with phenytoin. As I said previously, paraldehyde, a dose of 0.1 to 0.2 mg per kg per dose may be given IM or 0.3 ml per kg per dose mixed with coconut oil in 3:1 ratio may be used by rectal route. Additional dose may be used after 30 minutes and 4 to 6 hourly. Adverse effects of paraldehyde include pulmonary hemorrhage, pulmonary edema, hypotension and liver injury. Third one is sodium valproate. It is given per rectal or IV routes. Dose is 20 to 25 mg per kg per day, followed by 5 to 10 mg per kg every 12 hourly, and should be used with caution because of risk of hepatotoxicity in the newborn. Vigabatrin, it has been used in neonates with infantile spasm, and the dose is 50 mg per kg per day. Topiramate have neuroprotective effect against injury caused by seizures, and it has been used for refractory infantile spasm in infants. Pyridoxine, it is administered by intramuscular route. 50 mg of pyridoxine each may be administered both sides in either gluteal region or anterolateral aspect of thigh. Should be done in an NICU because hypotension and apnea can occur. Exchange transfusion, this is indicated in life-threatening metabolic disorders. Accidental injection of lidocaine, transplacental transfer of maternal drugs such as chloropropamide and bilirubin encephalopathy. Weaning of anti-convulsant therapy. Newborn on anti-convulsant therapy wean all except phenobarbital once seizure controlled. Perform neurological examination prior to discharge. If normal, stop phenobarbital. If abnormal, continue phenobarbital for 1 month. At 1 month, we repeat neurological examination. If normal, taper the drug over 2 weeks. If abnormal, we go for EEG, and if normal EEG, taper the drug over 2 weeks. If abnormal EEG, continue drug and reassess at 3 months. And this is done same at 1 year of age. Take home message. Most common type of neonatal seizure is subtle seizure. Clonic seizure and myoclonic seizure are associated with EEG changes. Subtle and generalized tonic seizure are without EEG correlate, and if specifically asked, generalized tonic seizure are without EEG correlation, non-epileptic seizures. Most common cause of neonatal seizure is HIE. Common metabolic cause of seizure include hypoglycemia, hypocalcemia, hypomagnesemia. Seizure occurring in a term well baby on day 2 to 3 of life is often due to subarachnoid hemorrhage. Meningitis should be excluded in all neonates with seizure by doing lumbar puncture and CSF examination. Monotherapy is the most appropriate strategy to control seizure when on maintenance. Attempts should be made to stop all anti-epileptics and wean the baby to only at phenobarbital 3 to 5 mg per kg per day. And when patient is neurologically normal prior to discharge, stop phenobarbital too. Thank you.